I am Dr. Ali, a board certified cardiologist with 32 years of educational experience. Today we're going to discuss post-stent exercise prescription for patients recovering from percutaneous coronary interventions or PCI. Structured cardiac rehabilitation is a critical component of secondary prevention. Clinical data confirms that cardiac rehab is strongly associated with a significant reduction in late luminal loss. Late luminal loss is bad. Sedentary controls have a lot more late luminal loss. The current exercise prescription is designed to leverage these benefits. Target is 40 to 85% of the heart rate reserve. You start exercise 2 weeks after the PCI and 50-minute sessions 3 times per week for a period of 6 to 8 weeks is recommended. Exercise acts as a therapeutic agent and fundamentally alters plaque morphology, reducing the size of necrotic cores and increasing fibrous cap thickness. Physical activity shifts vulnerable high-risk plaques towards stable, heavily calcified phenotypes. Physiologically, this is driven by endothelial support. There's increased eNOS activation, nitric oxide bioavailability, which promotes vasodilation. Inflammatory reduction by a decrease in the number of macrophages and matrix metalloproteinases is also noted, which preserves the structural integrity of the arterial wall. The CAC paradox, a point of clinical confusion, is that elite endurance athletes often demonstrate higher overall coronary artery calcification scores compared to the sedentary peers. This does not necessarily equate to higher risk. Morphology matters in athletes. These calcifications are typically isolated and mechanically stable. These plaques have a lower rupture risk compared to the mixed or non-calcified plaques often found in sedentary high-risk individuals. There's a U-shaped intensity curve noted. The Mark II study provides essential nuance regarding exercise intensity versus volume. We observe a U-shaped curve in cardiovascular risk. The benefit zone, moderate to vigorous training, significantly lowers cardiovascular mortality. The extreme zone with very vigorous exercise, more than 9 MET hours, may accelerate coronary atherosclerosis in some middle-aged and older male athletes. The objective is to utilize the dose-response relationship of exercise to maximize life expectancy without triggering excessive plaque progression through extreme intensity. Finally, for clinicians managing patients with elevated cardiac risk, the management approach emphasizes function over rigid restriction. Avoid over-restriction. Do not restrict exercise for asymptomatic athletes, even if they're present with high CAC scores of more than 400. Think about targeted intervention. Focus on aggressive treatment of traditional lipid risk factors. Utilize symptom-limited stress testing to safely assess cardiovascular capacity, as peak VO2 remains a more robust predictor of lethality than self-reported activity alone. Therefore, it is very important to note that just because someone goes to the gym and works out, the risk is not low. The risk is also determined by the lipid panel, blood pressure, diabetes, and overall health. Thank you for watching.